Good afternoon, good morning, good evening. Hello everyone, this is Sean Mayer, Clinical Lead for Person-Centred Care at the Scottish Government, standing in today for Brian Robson on this QI Connect session. A very warm welcome from the team here at Healthcare Improvement Scotland in Glasgow to this session. We're looking forward to a great session together. A record-breaking session today with nearly 1,000 delegates registered from many organisations, 26 countries around the world. And this QI Connect series providing opportunities for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. So these short sessions have been designed to be accessible and recorded to allow you to access at a time that suits you. Before we get started with today's session, I'm just going to hand over to Jennifer, who's going to walk us through some of the logistics and housekeeping for today's session. Jennifer, over to you.
Thanks, Sean, and welcome to everyone joining the session today. I'm just going to take you through a couple of quick housekeeping slides just to get us started, and we do want today's session to be fun and interactive. So if you could please use the chat function you see on the right-hand side of your screen to communicate, and we'll talk you through that in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So, as I said, these sessions are designed to be a fun, interactive learning experience. So we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. And there will be an opportunity for Q&A at the end of the session. So if you can see there the circle for the chat box icon, which looks like a speech bubble, just click on there, type your message into the box down the bottom right-hand side of your screen and press send. So we did promise today's session was going to be interactive, and this is the interactive part. We're keen to find out where you're going to be joining us from today. So if you could please select the annotation tool you can see in the top left-hand side of your screen. It looks like a pen. And then click on the arrow icon, and then click on the map to where you're joining us from. Wow.
Click, 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 here they come. Right, so lots of participants in Scotland and England, some in Canada, we see on the prairies there.
Big shout out to David Grayson, who is joining us from New Zealand.
Some in the Far East there, in Malaysia, by the look of it.
We're just seeing the UK disappearing under all those arrows, which is just amazing.
Great stuff. Now, someone looks like they're in the Arctic Ocean there. I'm not sure if that's someone from maybe Scandinavia who's slipped off the map a bit. Oh my goodness, there we are, back into the UK again. So we can see a huge number of people signing in from all over the world.
That is incredible. So welcome everyone to today's session. I am just going to hand you back. I was just saying more arrows flicking up there. I'm just going to now hand you back to Sean, who's going to tell you a bit more about the organisations and countries linking out to the QI Connect series as well.
Thank you, Jennifer. So we now have an incredible 787 organisations joining us for this QI Connect series, which is an incredible reach and opportunity to share learning across the globe. So a very warm welcome to all of you who are joining us today. So we're going to move on to competition time now. So Jennifer promised a competition, and a competition we have. There's even a prize. There's even two prizes. No expense has been spared here. Do we tell them what the prize is now, Jennifer?
Nope.
Okay, we save that, we keep that for later on. So the competition is, when I put up the next slide, the first person to click the flag for Lithuania will win the prize.
Oh.
Nobody's got it yet?
Keep trying.
Aha.
Oh.
is a finance management trainee here in the UK at NHS Lothian, one of our Scottish participants today wins the prize. So Eleonora, well done, and we've got a note of who you are and where you are, so we'll get that prize to you shortly. What is the prize? Here is the prize on the screen now. So a signed copy of Atul's book, Being Mortal, and the highly cherished, highly much coveted indeed, QI Connect mug. So well done, Eleanor. These will be making their way to you shortly. So we have 6 new countries joining us today. So a very warm welcome to Austria, Gibraltar, Indonesia, Lithuania, Pakistan, and Portugal. Fantastic to have participants from these countries joining in for the first time today on this call. We also have, initially this started off as one slide, I have to say. We now have 24 slides of the organizations who have signed up and regularly join into the QI Connect series. So here they are on the screen, passing before your eyes now, but you can see here that from all over the UK, from all over the world indeed, we have organizations joining up. We have organizations who are from the third sector, from the NHS in the UK, from providers all over the world, and even beyond health and social care too, educational organizations, and many more joining us in this QI Connect series. And for the first time joining us, here's our slide of first-time organizations here on this QI Connect. 81 new organizations for this presentation today, which is quite amazing. On the screen there, you see the British Heart Foundation from here in the UK, Child Advocates of CASA of Silicon Valley in the US. We have some of our NHS organizations, colleagues from the south of the border, Bristol and Sussex, and one of our health and social care partnerships here in Scotland. So these, as the slides pass on the screen before you now, are our new organizations joining for the first time here on this session. And of course, we're delighted to welcome all of our territorial NHS boards from Scotland who are now linking in to his QI Connect series. A very warm welcome to these providers of healthcare here in Scotland. We also welcome some new universities who've signed up for the QI Connect series. We have the University of Bradford here on the screen from England. We have the University of California, San Francisco, the Medical University of Graz, Australia, Trinity College, Dublin, Maastricht University in the Netherlands, the National University of Ireland in Galway, and as I've said already, the Lithuanian University of Health Sciences. And we're delighted, as always, to connect more widely with our regular universities and colleges from across the world. We have 68 in total universities and colleges now signed up and joining in to our QI Connect program. We want to also call out a very special welcome. So this comes on behalf of Brian, who's had some connections recently, Brian Robson, who normally chairs these sessions, recently with these organizations. So the University of Glasgow Oncology Society, Leslie Dawson here in Glasgow, also the Adept Clinical Leadership Fellows in Northern Ireland and Rachel Campbell, who Brian met with recently, and also a recent connection with Gerald Sendhofer and the team at the University of Graz in Australia. So a very warm welcome to these organizations with us here today. Now, the global reach of these sessions presents challenges. It means some people need to be up potentially in the middle of the night, which of course is quite unreasonable unless you choose to be up in the middle of the night. So these sessions are all recorded, and you have the opportunity then to play them back. And here we have on the screen a picture of our friends in Koaotea in New Zealand gathering staff to listen to the QI Connect session, to listen, to learn, and to share. And just a reminder that there's a back catalogue of previous QI Connect sessions here, so check those out on the Healthcare Improvement Scotland website if you want to tune in for earlier sessions or repeat, indeed, the sessions that we've had. We're also delighted that QI Connect still continues to be part of the ISQA Fellowship Programme, connecting people working on quality improvement across the world. and also a warm welcome to our Q members here in the UK. Q is a network of people working in health and social care, sponsored by the Health Foundation and NHS Improvement, to learn and share together in their improvement activity. So here's the people who are in the studio here today. Myself standing in for Brian. Brian, who's normally here, sending his good wishes to us all. Jennifer, who you've heard from. We've got Michelle working on registration here with us today. Jessica Ewell, who's the project officer, and Carmen, who also another member of the admin team. And Alex Sterling with us, working the Twitter and making sure that we keep track of what's going on in the world of social media as the presentation goes on. Also a special warm welcome today to Luke Yates, who's a specialty registrar in geriatric medicine here in Glasgow. He's also chair of the Scottish Academy of Trainee Doctors Group, and he's our guest questioner who's going to pose a couple of questions at the end of the session, at the end of Atul's presentation, to get the Q&A session going. So a very warm welcome to you, Luke.
Thank you for inviting me.
That's a pleasure, and we're looking forward to getting the questions going with yourself later on. So remember to tweet as you learn. There's the Twitter hashtag HISQIConnect, and you can follow us at his QI Connect as well. So get the conversation going on Twitter. So that's all of the routine and housekeeping and welcomes. Now we're moving to the main event. So very shortly we're going to be listening to Atul Gawande, MD. Atul is a surgeon, a writer, and a public health researcher. He practices clinically at the Brigham and Women's Hospital in Massachusetts in the USA, where he is a general and endocrine surgeon. Among many interests and activities, Atul is also professor in the Department of Health Policy and Management at the T.H. Chan School of Public Health, a staff writer for the New Yorker magazine, and the author of 3 New York Times bestsellers, including The Checklist Manifesto and Being Mortal, the latter of which formed the basis, the main subject matter when Atul delivered the prestigious BBC Reith Lectures in 2004. I could go on, but I'm not going to, because we want to hear from the man himself. Atul, a very warm Scottish welcome from the team here at Healthcare Improvement Scotland in Glasgow, and indeed a warm welcome from all of the His QI Connect participants tuning in from around the globe. We are looking forward to what you have to say to us, and I'm going to hand control now over to you so that you can...
Excellent. And can you hear me now?
You're coming through loud and clear.
Excellent. Well, thank you for the introduction. Thank you for the chance to talk to this community. Thank you to everybody who showed up, and I'm still Googling what the Lithuanian flag looks like, so you have to give me another minute here. But the opportunity to get to talk to you about, the subject for a group that's focused on safety and quality, the puzzle of what does safety and quality mean for the care of people with a terminal illness, the care of people who have unfixable problems, is the one that got me started writing on this subject in the first place. What does it mean for us to be really great at what we do in these instances? I want to start with a story that I wrote about in the book, but I'll show you the person and who they are. This is Peg Batchelder. She was my daughter's piano teacher, and my story about her starts when I got a call from her husband telling me that she was in the hospital. Peg was my daughter's piano teacher when my daughter was 13 years old. We'd been with her long enough to know that she'd in fact gotten through a treatment for cancer several years back. She had a rhabdomyosarcoma, which is a cancer of the soft tissue of the pelvis, and the sarcoma had invaded into the bone but was only local, and she'd gone through what she called her year in hell with surgery, chemotherapy, radiation, but she got through it. There was no evidence of disease when they were done. She could return to her life in teaching, hobbled, but at that point, really only by having to walk with Canadian crutches, the crutches that go around, attach onto your forearms. So she was back doing yoga. She couldn't do bicycling like she used to, but she could still take her dog out. And most importantly for her, she was able to get back to teaching her students. She was now 62 years old. She was remained with an excellent prognosis. But then she developed, as we'd learned a few months before, a complication of her chemotherapy emerged, myelodysplastic syndrome, a leukemia-like condition that can be caused by chemotherapy. So she was detected to have dropping blood counts. She therefore needed to go back onto now a different kind of chemotherapy to address this leukemia-like condition. And she was determined to keep on teaching. And so she would take her therapy. We would occasionally get a call that the lessons that my daughter was taking had to be moved to a different date or postponed for 1 week. But you know, she had Peg had managed, and it had been pretty remarkable. We got phone calls, however, for the 3 successive weeks that she was postponing the lessons. And we didn't know why, but it was unusual that that was the case. And so when I got the call from Martin saying that she was in the hospital, I kind of knew something was up. He put her on the speakerphone for their iPhone. They were both there in her hospital room, and I asked, "What's up?" And she said that her treatment for her myelodysplastic syndrome wasn't working. She ended up developing fevers. The thought was that maybe she had an infection. Her blood count, her white cell count had dropped exceedingly low. They did a scan to try to find where the infection might be coming from. And what they found was that the cancer was back. Not the myelodysplastic syndrome alone, but in fact her rhabdomyosarcoma had returned now in another part of her pelvis and had spread throughout her liver as well. So now here she was in the hospital. She was admitted with difficulty controlling her pain. She had become incontinent because of difficulty moving and getting to a bathroom in time. They were treating her with daily transfusions now to maintain her blood counts. She was on pain medicines for her pain, steroids for the tumor fevers. The team told her that there were no conventional chemotherapy options that she had. She had the possibility of going on an experimental therapy of giving her high-dose chemotherapy and treatment and doing a bone marrow transplant experimentally. There was an offer of that kind of possibility, or they told her, we could keep you comfortable and make sure you're not in pain. What she heard was, we can try to do something, or we can do nothing. And what she wanted to know was, what should she do? And I have to say, this, for me, was the moment that I struggle with. I'm a cancer surgeon primarily, and when I'm faced with this question of what to do, I've never quite been clear, how do I go about understanding how to walk through that moment with somebody? It comes up with, here with a friend and teacher of my child, comes up with patients, comes up with family. All of us, I think, who are in practice clinically, have these kinds of questions come up. But I think it's also the moment that we struggle with as a society, as healthcare systems. And the question that we're struggling with is what do we want for her in that moment? What do we think it means to be excellent here? Do we do anything, no matter what, offer whatever possibility there might be, or do we just say, you know, we're going to keep you comfortable. We're going to make sure you don't suffer. And what always felt clear to me is that offering up that option never felt like it was very successful. It never felt very good. It never felt like I was clear about what we were really trying to accomplish. And what I realized, and became the way I opened my book, Being Mortal, was that I'd learned a lot about a lot of things in medical school, but mortality was not one of them. The focus in my training, medical school and surgical training, had been on how to fix people's problems, and there's nothing a surgeon loves more than the opportunity to fix a problem. But then I came into my practice realizing and experiencing how often the people who were coming in to see me were seeing me about unfixable problems, sometimes a terminal condition, sometimes chronic conditions that we weren't going to be able to make go away. And then the puzzle was, what does it mean to be excellent? What is our job even in those situations? I was, you know, as I dug into the problem, I ended up doing interviews with more than 200 people who had experience with serious life-limiting illnesses, whether as patients or as family members. And then I also interviewed scores of clinicians. And among the, I did a lot of research on the studies that were out there. Among the studies, the many studies in the field that I really had not been aware of, was this study, which was emblematic of the kind of results that I was finding. It was being led by a team at the Massachusetts General Hospital under a researcher named Jennifer Temmel. And what she was looking at were people who were undergoing therapy for advanced lung cancer, stage 4 lung cancer. The average survival in the trial was just 11 months. There were no survivors beyond 3 months. There was a terminal condition. But we're in an academic institution that also offers the opportunity to participate in research trials, and perhaps, and some trials which have turned out to have had a remarkable effect in helping lengthen people's lives. And so the trial that they ran was one in which half of the patients were assigned to receive the usual oncology care, and the other half of the patients were assigned to receive the usual oncology care plus a palliative care clinician to see them as well. And the group who got a palliative care clinician right from the beginning of their therapy, right from the beginning of diagnosis, not just when you're coming to the end, that group ended up having a remarkably different course than the others. You can see on this graph that this group was 50% less likely to still be taking chemotherapy when they'd also been seeing a palliative care physician alongside their oncology physician, 50% less likely at 2 months before they came to the end of life, and they were 80% less likely to be on chemotherapy in the last 2 weeks of life. They also had markedly better measures of having less suffering. They had lower rates of severe anxiety, for example, as well. They spent more time at home. They had about 1/3 less chemotherapy, 1/3 less time in the hospital, and as a consequence, 1/3 less costs. They started they chose hospice care more often and started it earlier than the standard group. And here was the kicker. Let's see if we can, there we go. Here is the survival curves. And what you see is that the group who received their early palliative care lived 25% longer on average. They were doing better. They were stopping therapy sooner, and they lived longer. That was incredible. That was extraordinary to me. And you have multiple studies showing that this just happened to be the most rigorously done, showing that involvement of palliative care early on was very powerful. So the question becomes, how do you scale this? And that led to my interviewing the people, some of the people who participated were the palliative care physicians in this trial. Because my question was, you know, one option for scaling it is that we say everybody should have a palliative care clinician from being diagnosed early with any kind of serious illness. Because the palliative care clinicians see their focus as, how do I assure that we use our medical capability to give you the best possible quality of life, and not just quantity of life, while the oncologist works on the quantity of life. And there are two problems with that. Number one, we don't have anywhere near enough palliative care clinicians or geriatricians, for example, who also look at those kinds of questions from for people with very old age. And we don't have nearly enough. We couldn't meet 5% of the population's needs if we were taking that on. But second, there's something wrong with the idea that you go see this one clinician who helps you with your quality of life and another for your quantity of life, and somehow you're going to integrate it all. And talking to them, what I realized they were explaining to me was a fundamental change in my conception of what my job is as a clinician. That the fundamental change in conception was, I had thought of myself as someone whose role is to be as informative as I possibly can be. I want to be talking to you about the facts of your situation, your options, option A, option B, option C, and then we're going to talk about the pros and the cons and the risks and the benefits, and then I'll turn to you and I'll say, what do you want to do? And more often than not, people would look at me and they would say, what do you think I should do? And I'd learned in medical school to say, well, that's not really for me to decide. That is, there's no wrong answer here. It's according to what you really feel, what your values are, so what would you like to do? And I can't tell you how often they felt lost, or they made choices where I thought, oh, I don't think that's what you really, really, really want. Or I would find myself pushing or arguing one way or the other, and not really understanding how to do better. And what these palliative care clinicians, geriatricians, hospice workers I met were telling me was essentially that the role I was playing was being a technician. But if we're really going to be the real clinicians, then we are learning how to be a counselor. And a counselor knows how to ask you your goals and then offer you direction and choices. And not just choices, but say, well, if this is what's most important to you, then here is the option that gets you your best chance of achieving that. The way I'd summarize it is by saying that, and this is kind of duh, but the key lesson that came out of all of that, you know, interviewing all these people, everything else, was that people have priorities in their life besides just survival. They have priorities for their quality of life as well as their quantity of life. In order to learn those priorities, we have to ask people, but we don't ask. It's important that we ask because the priorities are different from person to person, and also because people's priorities change over time as they experience what they're experiencing as they go through a serious illness. But we ask less than a quarter of the time as clinicians for people facing the possibility of the end of life. And when we don't ask, the result is that our care is often out of alignment with people's priorities. Therefore, the result is that people have suffering. And I could see that in the case of Peg Batchelder. You could see it in the hospital. She was suffering. They had given her options, but neither she nor the team had any ability to elicit what her priorities really were. Complicating this was that, in fact, neither she nor her team had any imagination of what kind of life worth living is possible. And that's where the challenges are. What I saw from Temple study interviewing people is that when we do ask, you can get extraordinary results. But how? How do we ask? What I didn't get into in the book, which I get to talk about with you, is the kind of practical tools that we've begun testing in our research center, Ariadne Labs, where I lead a group of people working on creating scalable solutions for better care delivery from birth to the end of life. And our team working on the Serious Illness Program developed a guide that's broken into a few sections, and it's difficult to read here, but basically it's about guiding, offering a set of questions that you can ask to set people up for the conversation. I'd like to talk to you about what is ahead with your illness and do some thinking in advance about what's important for you. Is that okay? Asking what's your understanding of where you are with your illness. And then some questions that help you guide towards what is your, how are you doing, and what are your priorities, and what's most important to you. And there's simple questions like, what are your fears about what might be ahead with you? What's the minimum quality of life you find acceptable? What are the trade-offs you're willing to make and not willing to make in your care? What are your goals if time becomes short? I told about one patient who said, minimum quality of life, well, if I can eat chocolate ice cream and watch football on television, that would be good enough for me. It was the best living will ever. Because now you can give recommendations. Now you can give guidance based on the options in front of you, because he was able to come to and be able to describe what mattered to him. Not everybody can, but I was on the phone talking to Martin and Peg, and I decided, you know, I'd learned, we'd learned these questions, and I decided to try asking them. And so I just went through a few of these questions. I said, what's your understanding of where you are with your illness at this time? And she said flat out, I'm going to die. There's nothing more they can do. And there was anger in her voice. She couldn't believe they'd let her get to this place. Martin told me later it was the first time he'd heard her articulate that she was going to die. I then asked, well, what are your goals if time is short? And she said, I don't have any that I can even see possible. And then I was a little flustered. No one had told me what I do when they say that. And so I just went on to the next question. So I asked, so then what are your fears for the future with your health? And then she gave me a litany. She feared facing more pain. She feared suffering the humiliation of losing more of her bodily control. She feared dying in the hospital. She'd been there for days, she said, and I am just getting worse. And what she was describing was what matters to her. I'd been, as part of my interviewing, I followed a hospice nurse as she went on rounds. And she said something to me after we'd come from visiting a woman who had been with shortness of breath, facing clearly very difficult situation with advanced congestive heart failure. And I said, what's your aim? What are you trying to do? And she was very clear. She said, the nurse said, my aim, you know, medicine's aim is to sacrifice your time now for the sake of possible time later. But she said, my aim is instead to give people their best possible day now, no matter what that means for the future. Now, ironically, it's almost then that when you do that with people, when you try to give people their best possible days now, when they face a serious life-limiting illness, that they often, that on average, they have equal or longer life expectancy. And that's what I was seeing. So I said to Peg that I'd met this hospice nurse, and she'd explained to me that their goal is to give you the best possible day that they can under the circumstances, and that it seemed like it'd been a while since you'd had a good day, Peg. And she said, yes. Yes. It's been a really long time. So I said, is that worth hoping for? Is that even worth fighting for, to have one good day? Then maybe that was our goal. 48 hours later, she was going home with a hospice nurse waiting for her to meet with her to see how they might be able to give her her best possible day, and maybe her best possible days. I broke the news to my daughter, Hunter, that she would not be having any piano lessons anymore. Peg was dying, and she was struck low by it, that she would likely never see her again. And then a few days later, we got a call, and it was Peg on the phone, and she wanted to know if Hunter was willing, and we would let her, whether she could resume teaching her again. And that was more than Peg or I ever imagined. I ended up meeting her nurse, her hospice nurse, a woman named Deborah French, and asked Deborah, how did that come about? And she said when she arrived, they talked through, what did Peg care about, and then went about making it happen. And at first it was just the daily difficulties of life, getting her pain under control, getting her a hospital bed in her dining room so she could recover without having to go up and down, or she could live without going up and down the stairs, get a bedside commode so she could actually get to the toilet without fear of soiling herself. They arranged ways to do bathing and dressing. She got and as her pain came under control, as they increased her medications, and all of these steps came into place, her anxieties fell and her sights began to lift. And then Martin told me, he said, she became focused on the main chance, coming to a clear view of how she wanted to live the rest of the days. She was going to go home, and she was going to teach. And that took medical expertise. That was not just, we're going to make you comfortable. We're going to leave you be. We're going to make sure you're out of pain. It was calibrating the pain medication so that she could teach, that she wasn't in so much pain she couldn't teach, but not so groggy that she couldn't be functional. It was tuning all of that, and it became possible. Martin said she was more alive running up to a lesson and for the days after than he had seen her in weeks. She had no children. Her students filled that place for her. And she still had some things she wanted them to know before she went. She wanted to be able to say her goodbyes, give her parting advice. Medicine's forgotten how vital such matters are to people as they approach life's end. People want to share their memories. They want to pass on wisdom and keepsakes. They want to connect with loved ones. They want to make some last contributions to the world. And that's how life achieves meaning. That is part of the mortal lifespan. And yet we're oblivious to it. We've had a kind of 50-year experiment in medicalizing mortality by becoming the technicians. And the key is to recognize we have to be the counselors. And that's a deep change in our job. It can seem like the obvious answer of what our job is, like we know what our job is. We help people achieve health and independence. But then what is our job when that's not possible anymore? When they're not healthy and when they're not able to be independent. And you realize that we are lost in those moments. And it's not just about the end of life. It's why this is about serious illness that can threaten to impair your quality of life or your quantity of life, And it also forces us to rethink something about our pattern of life as well. The pattern of life we envision for ourselves nowadays in a modern world where we have medical capability that is enabling people to live on average 80 years when you have access to it, is that life is a state of steady health followed by a crisis event, a catastrophe that we can rescue you from. It may be a heart attack, it may be a car crash, and then we can get you back to your state of health. And then you advance further on in life, and you have another crisis event, and then we bring you back again to your steady state of health. And that it goes on this way until we just can't do it anymore. But that's not, in fact, what the pattern of life really looks like. Instead, what we see over time is that life is starting at often an excellent state of health, but then having a crisis event, and then we can rescue you from it. And if you have good primary care, we might even be able to prevent it and push it out a little further. But then when that event comes, we rescue you from that event, but you don't get back to being just the way you were. You now are with a chronic illness, and then another event happens, and you may now come to another state with that chronic illness or another chronic illness. And life then is the management of chronic health issues. And our goal is larger than just health and independence. Our higher purpose is well-being, even in the face of health, of disease and disability. And that's a different job, and the key things to understand is that that involves eliciting people's goals for their physical function, their cognitive function, their emotional life, aligning our care and managing those goals over time, and then coming to, I think, a pretty fundamental bottom line that is quite a different way about thinking about the safety and quality of care. It's to help people and ourselves imagine a life worth living, and then use our medical capability to enable it as much as possible. Our goal is not survival at all costs, nor is it a good death. Our goal is a good life, as good a life as possible, all the way to the very end. Here is Peg. And Peg got to fulfill her final role. My daughter had 6 weeks of lessons with her, and it was followed by 2 final concerts, one with her students from around the country who had already graduated from her and were in careers around the country who came back together to play a concert, and then a concert with her students from elementary age to high school age, playing Brahms and Chopin and Beethoven in her living room. And this is her at that final recital after all the students had played. She died 1 week later peacefully in her bed. But my final remembrance of her is this moment. After it, she took each child aside and gave them a personal gift of her own and a few words. And to Hunter, she said, she gave a book of music. And then she told her, "You're special." And that was something that she never wanted any of the kids to forget. Thank you. Happy to discuss, answer questions, and talk about what it means to include this work in your quality improvement.
Atul, thank you so much. That's great. Lots of food for thought there, and lots of questions coming in on the Twitter feed and also through the chat on the WebEx here, and we're going to try and work our way through some of these now. But before we do that, I'd just like to reintroduce Luke Yates, who's going to get the questions going. Luke, just to remind you, is a doctor in training here in Glasgow. He's also chair of the Scottish Academy of Trainees Doctors Group. So Luke, questions for Atul?
Thank you very much for a very enjoyable talk. In my own clinical experience, I've encountered a lot of people who have never really thought about these concepts, have never thought about the idea of priorities or making trade-offs, making choices towards the end of life, or even that they are approaching the end of life. And well, often what they say is they just want everything done and they don't really want to explore that in more detail. What advice do you give to doctors when they're faced with that sort of situation as to how you open the door and move the conversation towards what you've been discussing about important priorities and helping them make decisions that are important for them?
So we've been implementing this approach in the Dana-Farber Cancer Institute and the Brigham and Women's Hospital at large scale across the entire institutions. And part of what we're doing really is beginning to, you have to move this conversation to happen earlier, to happen more, and to happen better. And to make it happen earlier means to recognize that it's not when they come in crisis that this conversation needs to happen. There's a lot going on in that moment of crisis. It's to begin to make the conversation happen. So we've been using the surprise question, which is, would you be surprised if this patient would die in the coming year? When we measured in cancer care populations, if people were not surprised that the patient were going to die in the next year, it was a 50% chance they would die in the next year. So it wasn't a total diagnosis, but it was a clear sign that they're at high risk. For a primary care population, it was about a 15% risk that they die in the coming year. And you had to tune it a little bit more to not only would you be surprised, but, you know, do they have a condition that makes it seem that this is a concern? And then it's a conversation that is about, you know, what are your priorities if your health worsens? Asking these questions and just asking permission to have this conversation. Often people aren't ready for it, but you've opened the door. It's not, you're not looking for an epiphany. You're trying to create a process where this becomes a normal line of discussion of what you do. And it's also hard. I found, as one of my colleagues put it to me, that, you know, in order to take out gallbladders, I had to do 30 gallbladders in a row before I began to get the hang of it. And in the same way, having these kinds of conversations where your goal is to elicit people's goals and listen at least half of the time and ask questions that get them being able to talk and being able to do it in your way is really vitally important. So yes, people will say, well, I want everything done. The question is not, do you want to fight or do you want to give up? The question is, what do we want to fight for? You want everything done for what? What are you willing to tolerate? What are you not willing to tolerate? What's the minimum quality of life you would find acceptable? What are things that really matter to you that you want to make sure that we're honoring and not taking away? Oh, you want to get to a wedding, or you want to be at home as much as possible. My father did not want chocolate ice cream and football on television. He wanted to know that he could be at the family dinner table as he went through a brain tumor that would ultimately make him quadriplegic, and be able to converse with people and talk. And if that ability to be at the family dinner table with friends and family, eating and enjoying conversation is no longer possible, then just let him go, keep him out of pain. And that became our guide point, and it's possible, but it's all about initiating earlier, getting comfortable, asking the questions. Okay, you want everything, but we're going to fight for you. Fight for what? Help us understand and prioritize here.
Thank you. So thanks, Atul, for that. There's a load of questions here that we have coming through. So I'm going to try and ask questions which will bring together a few of these. We had a number of questions perhaps related to how you were finishing there about having these conversations more often, more frequently, and better. but actually there's not a lot of time, some of the questions coming through, looking at the amount of time dedicated, if any, to teaching doctors and other healthcare professionals, for that matter, how to deal with mortality and how to have these questions. So the question kind of was something along the lines of how could or should we teach medical students and doctors in training about mortality and palliative care. That came from Sam Blackley, who's a medicine for the elderly doctor in Lothian, from Paul Coulter, from Nina McGinley, a number of others asked a similar question. So Atul, how could or should we teach people to cope and deal with mortality?
In the state of Massachusetts where I live, we just reached agreement with all the medical schools in the state to incorporate this into their curriculum. And it's been a challenging discussion. It's taken us months of going through the curriculum and really understanding what people's experiences are, because teaching a class does not mean it's incorporated into your clinical training and you're advancing along the way. We will make public I think within the next few months the competencies we've identified, but I'll just name the basic ones because it's really simple at some level. There's a set of skills around breaking bad news. Many medical schools do teach that and have people practice with role-playing or actors as patients. But then it's also being comfortable with and eliciting people's emotions about where they are, so being able to ask, where are you with this illness? And how do I deal with and manage the emotions that are going to come at me and get some practice at that? How do I be silent in those moments and that kind of thing? And then the further part is then to be able to explore people's goals and priorities. There are certain things that people are really not ready for in the medical school, and we've identified that as well, that really have to happen in training or sometimes even beyond. Prognosis, for example. Being able to discuss prognosis is really a high-level task because you have to understand the literature, you have to understand how this person fits and does not fit into what the current state of treatment is. But then also there's how do you elicit and understand, how do you want to hear about what might be ahead with your illness? How do you want to discuss it? And having some frameworks for being able to use for passing on that news. And so what we've come to recognize is a building block of skills that have to advance along the way. And many of us as clinicians, experienced clinicians, never had those building blocks. And so we also have to have faculty development to teach people how to teach these things. And so when we've been deploying at the Dana-Farber, it's been through having palliative care clinicians and geriatricians become much more integrated as part of teaching us. So we actually have made it so they are population health managers for the end of life for people with any serious illness, and identify when people are and helping walk their colleagues through a curriculum around us advancing our skills as well. So we actually have assigned that they spend 50% of their time teaching, doing consultations with patients and that kind of thing. But we are now funding them to look at, are we making these conversations happen? Are we driving them? Are we teaching them? And then they coach us around our skills development along the way. Not all of us are open to it, but we've gotten to the place that 92% of patients now have these conversations before they come to the end of life. They're happening at 5 months before death instead of just a few weeks before death. And they're much better conversations. We're documenting that they are not just DNR conversations, which they were half the time. They are now about, they incorporate people's goals and then starting to put treatment plans that match up against it.
Thanks, Atul. Perhaps time for one more question. There's quite a few questions about palliative care, the term palliative care, and also the distinction between, okay, we're going to stop now, we're going to stop standard care and switch to palliative care, and whether we should actually stop making that distinction, and whether this good conversation about the things that really matter to you should become standard care, and that should be the guide, if you like, for what follows. What do you think about that?
I think this is incredibly important. I used to say, if people said, I'm thinking to see someone in palliative care, and I would say, oh, no, we still have options. You don't need to do that yet. And these trials and the experience and going through really has taught me that the role of palliative care is much earlier and can be involved right from the very beginning. At the most mature level, what people are distinguishing now between is primary palliative care and secondary palliative care. Primary palliative care is the kind of palliative care that I ought to know how to provide now, which is understanding people's goals and priorities, having a capability of discussing and exploring how people understand prognosis that they're facing and what might be ahead for them if things go well and what might be ahead if they don't go well, and then being able to tune the treatment to maximize the goals against that reality of the range of possibilities that might be coming up. And that's what's called primary palliative care and should be able to be something that everybody provides. And palliative care is not just about the end of life. It really is about, palliation implies that, it's only there when there's no other options. But really what it's about is offering solutions for people's quality of life even as they go through an advanced illness that they may well, come through and do well with. So the secondary palliative care is the complex cases, the patient who's in denial, the patient with severe family conflicts and people are not able to agree with or tolerate the decision the patient makes about what their goals are or where they're going with their care, or just conflict among the team about the care the patient may have chosen to undergo. So palliative care in our future should be that secondary role. They get the 5% of patients where we've struggled with tuning their quality of life. Maybe it's also that, we haven't figured out how to get the pain meds under control or the nausea under control or things like that. So there's a range of those skills, and that's where we need to advance to. And we really need to be more partners with them and with our geriatricians to really be whole care. We should be cutting-edge care for the quality of people's life as well as the quantity of their life, and that is in our capability.
Thank you so much. That's a great note to end on, I think. So it remains just for us here in Glasgow to say thank you very much, Atul, for speaking to us today and for taking the time to spend with us today. Thank you to all our participants on the line. And I'm just going to wind up by reminding you that we have our next QI Connect session on the 31st of May between 4 and 5, and we're looking forward to hearing from Toby Cosgrove, who is former president and chief executive of the Cleveland Clinic, and he's going to be talking to us about empathy and the story of how the Cleveland Clinic made that their core business. So it's something, that human connection, which links very strongly with the things that Atul has been speaking to us about today. And just to draw your attention to this dazzling array of people that we have speaking to us here over the next number of months and the rest of our QI Connect series this year. Please join us and tune in to hear from these guys as well, because I think we can guarantee that we'll have stimulating, thought-provoking and inspiring messages and discussions when we hear from them also, as we've done today from Atul. So thank you very much, everyone. Thank you, everyone here in Glasgow. Thank you to all our participants, and a very special thank you to Atul for taking the time to join us today. Goodbye, everyone.